I won't reintroduce Dr. Fawcett, who already spoke at 10 o'clock this morning, but he is giving our lunch lecture, and he will be speaking about suicide and in our medical practice, which I think is a fairly under-recognized and under-treated problem. Dr. Fawcett.
Hi again. What I really want to know is everybody drinking the Kool-Aid? That's become quite a saying these days. I'm going to talk to you about suicide medical practice. I've got this disclosure slide so you can see if I have any slants in my talk. Actually, Merck didn't even make a psychiatric drug until recently, when they just gobbled up a couple other companies like Wyeth, and I guess they merged with them. I just wrote some chapters and edited some chapters in the mental health area for them. Now, before I start on this, I just wanted to mention what I'd rather be talking to you about today is the miracle of consciousness and how we can nurture it and defeat time by learning to appreciate our consciousness. But since I have no data on that, just opinions, and I'm going to talk about suicide, which is an interest I've had for the last 40 years. So, starting out, some basic statistics, mainly on suicide statistics from the U.S. Suicide is now the 11th leading cause of death in the U.S. It's the third leading cause of death for people aged 15 to 24, behind accidents and homicides. It's the second leading cause for ages 25 to 34. It's also the second leading cause of death for college students. Just for relative comparison, homicide is 13th cause of death. In 2005, it was estimated there were over 800,000 plus suicide attempts. A lot of them aren't reported. It's hard to estimate the number. And an interesting take on suicide, if you think suicide is caused by stress, black women, who I think you could argue are not, I don't think you can argue they're subject to less stress than most of us, have the lowest rates of suicide and have had over the years. Very low rates. Now, last year in 2005, there were 32,637 total suicides in this country. That came out to a rate of 11 per 100,000. Our suicide rates vary between 13 and 10, and so that's in the ballpark. The ratio of suicides male to female is 4 to 1, although 5 times as many females make suicide attempts as do males. The elderly rate is high. You can see it's higher than the mean rate, as you would expect. And the youth rate is, and there's a typo here, I always find one when I'm giving the talk, is 10 per 100,000. It's a little lower, but it's still disturbingly high. Now, it was as I said, it was estimated there were over 800,000 suicide attempts in 2005, and that figures one. And there was, if you take that with the figure of suicides, that was one suicide for every 25 plus attempts. So you see that suicide attempts are very common, and suicides are relatively rare. But if you have a clinical diagnosis like bipolar disorder, as I mentioned in my talk on bipolar disorder, the ratio is 1 suicide for every 3 attempts. So diagnosis does matter in this realm. Just a fact that you might know and might be interested in is that the rates of suicide are highest in the Intermountain states, including this state, and Alaska. They're 3 times greater than the eastern states. Nobody's been completely able to understand that. There's a number of hypotheses. One is that the distances are longer, people don't get help here. That's being refuted by a study here in Utah at the university. The other, my favorite one was that people who move west, there's a high proportion of people who want to be left alone and independent and maybe more less likely to ask for help. That's a possibility. There's even someone at the University of Utah, and I can't remember his name, maybe someone in the audience knows, who has a hypothesis that suicide rates are related to altitude, which I think is a very interesting hypothesis. So we have much higher rates than, say, California or Washington or Oregon in this state, in these states, in New Mexico and Utah. And I don't think it's. I also don't think it's related to gun ownership, because gun ownership's pretty big in some of the major East Coast cities too. So it's an interesting fact that comes up every year on the statistics. Now, physicians often see patients before they suicide, and this one review by Luoma reviewed 15,578 cases of suicide and found that 45% of suicides had contact with a physician within 1 month of their suicide. And that's been a statistic that's been upheld a number of different studies. Now, they also published that 19% had contact with mental health services within 1 month of suicide. So general physicians have a broader net of contact with patients within a month of their suicide than mental health professionals. And of course that includes social workers and psychologists and the whole realm of mental health professionals. Now, in an older study of Robbins back in the mid-50s, they found that 50% of the sample that they studied of 114 suicides in St. Louis saw a psychiatrist recently. So it may be somewhat higher in patients seen by psychiatrists as a medical specialty. Mainly, they may see more severe cases, or they may get referred cases that are at higher risk. One study of 77 cases of suicide published fairly recently found that 30 had visited, 30 out of 77 had visited their physician in the last month before suicide, 14 in the week before their suicide. In 30% of the suicides, the reason for the visit was a mental health problem, compared to 3% in a control group. So a certain percentage of these patients do present with mental health problems to general physicians that are on their way to suicide. So the question is there anything that general physicians, any kind of screens? I know they're busy, they're looking for they're dealing with all kinds of problems. Is there any kind of screen that would help bring out any of these risk people? In a study that I didn't have on a slide of elderly suicides in Cook County, Dr. David Clark found that a very high percent of the suicides had histories of seeing their physician for multiple physical problems, resulting in multiple negative tests. And the physician, and they never said they were depressed, they never were diagnosed with depression, but they had these multiple physical symptoms. And we know, of course, that physical symptoms are very common in depressed patients, and we now know some mechanisms for this. For instance, we know that inflammatory cytokines are released from the brain when a person is depressed and are shut down when their depression is treated. So there's an overlap between physical complaints and depression and suicide. And trying to, maybe if that could be teased apart a little better, we could help the general physician to recognize some of these high-risk patients. There's a lot of medical conditions associated with suicide, and of course the biggest is alcohol use. There are papers showing that alcohol use trumps every other diagnosis. It's a risk. Alcohol abuse, not use. Alcohol abuse trumps every other, all the other diagnostic categories on its own, can stand on its own, is a factor in suicide. Other drugs, of course, opioids and IV drug use also is associated with elevated suicide rates. Chronic pain, which many of you are seeing, has a interesting increase. The risk is doubled and is reported in ulcer pain and uterine pain by Tang. There's been many papers written on this, that patients with chronic pain are at higher chronic risk for suicide. And I want to start insinuating the term chronic versus acute risk in my talk here, because this is the biggest dilemma in the prevention of suicide by a treating person. Many people have chronic risk factors for suicide. They're at chronic high risk for committing suicide someday in the future. But what physicians don't have much data on is what factors would show that the patient's about to do it in the next day or week or month. That's the hardest part in suicide research, and it's been relatively neglected because it's so hard to do. Cancer, of course, is associated with higher risk of suicides, particularly within the first year of the diagnosis being made. Not necessarily in terminal patients or patients that have well-defined severe cases of cancer. It's just the effect of the diagnosis, the shock of the diagnosis seems to be a stress that brings out the risk for suicide in patients. And by the way, when I say suicide, I mean suicide, not suicide attempts, because there's obviously a lot of difference between the two. Multiple sclerosis, another condition that's associated with higher risks of depression and suicide. Epileptic patients also, this one study by Bell found that it even occurred in epileptics without comorbid psychiatric diagnoses. And of course, Huntington's disease is the classic neurological disease which has very high rates of suicide. It's associated with a family history of suicide, being not married, and depression in a report. Now, a recent study of suicide in general practice showed that only 20% of patients seeing general physicians had a psychiatric diagnosis that committed suicide. They had a high rate of somatic symptoms, as I mentioned before. So there's a lot of support for that particular presentation. Suicide occurs in many psychiatric diagnoses. This study is, although it's a 1997 study, it's a fairly old study, is the most complete review of the literature in this area of suicide and psychiatric diagnosis. You can see here that Harris and Barraclough listed the number of studies that were available. And then they listed the standardized mortality rate. And just so you understand, if you don't understand what that is, a standardized mortality rate is the expected death rate for a given population, a given age and sex. And the normal is 1. So 38, an SMR of 38 means 38 times risk of suicide in people who have made any prior suicide attempt. That turns out to be the best predictor long-term of suicide. Now, if you follow a sample of patients who have made suicide attempts, the average number that actually suicide are about 12.5%. So about 88% don't kill themselves. Yet, every study of suicide risk factors comes up with this is the strongest predictor over time. Now, this particular listing of diagnosis has a surprise in it, which is eating disorders had a higher SMR than major depression. This is the only paper that's ever found that, the only review. And a lot of my colleagues who give talks on suicide, when they present this paper, leave that out because it doesn't fit. But I think it's important. Eating disorder patients have a lot of mood disorders, and I think it's comorbid mood disorders that make that such a high risk. Notice major depression. There's people who will argue that bipolar disorder, which is down here under mixed drug abuse, is greater than major depression. Goodwin and Jameson have made that argument in their famous book on manic depressive illness. And it all depends which literature you review. But I think the important thing is that they're both very high risk. If you go down the diagnostic conditions, you see that suicide does occur in virtually every psychiatric diagnosis. No diagnosis is exempt. But of course, comorbid depression can occur in any of these disorders. So notice that the only diagnosis that didn't have an elevated SMR is mental retardation, which I thought was interesting. Now I want to switch for a minute to the FDA black box on antidepressants, because I know that the highest prescribers of antidepressants are general physicians, not psychiatrists, because there's only 35,000 psychiatrists in this country, and most depressed patients are seen not by psychiatrists. In about 2005 or 2004, the FDA, after some analyses, decided that there was a higher suicidality rate in the studies, 4% versus a placebo percent of 2% in the FDA studies. In order to get significance, they had to add all the studies across all the drugs to get this. Now, no suicides occurred. There were roughly 5,000 adolescents and children in these FDA studies added together. There were no suicides, but there were patients who, after taking antidepressants, voiced suicidal ideation or made gestures or even attempts. An attempt should be when the patient desires death, intends to die. A gesture is when the person wants attention or help and does something that's self-harming. But this got interpreted in the press. They left out that no suicides occurred. And it was written as if these drugs caused suicide. This led to a decline in their prescription by about 20 to 30% in this country. And during that time, the suicide rate in adolescents increased. Very interesting question about policy and what good policy is by the FDA. So a lot of people became frightened to use these medications when that black box appeared. I want to show you one study on this by Greg Simon, who does a lot of large sample studies. In this case, he had 65,000 patients with 82,000 episodes of antidepressant exposure. He verified suicide by state and national death certificates. He looked at suicide attempts leading to hospitalization. In this sample, he had 31 suicide deaths, 1 per 3,000 treatment episodes. There are 76 serious attempts, which meant the patient probably was at risk for death from the attempt. He found the risk of suicide was not higher the month after that and subsequent months. In other words, there was no increased signal for suicide in people treated with antidepressants. He found that the risk of attempt was highest the month before treatment, before the treatment was started. And he also looked at the SSRIs versus the older tricyclics, and he found that there was a little higher risk for suicide in the first month on tricyclics, but it was not true for the newer medications. And I'll show you some of these plots. You can see, as you go from left to right, you can see that you're at minus 3, minus 2, minus 1, and then you start, that's when the drug was prescribed, and then you go 1, 2, 3, 4, 5, 6, and these are rates, in this case, of suicide attempts 3 months before and 6 months after initial antidepressant. And the graph on the right are patients less than 18 years old. And you can see the very high rates of suicide attempts in these patients on the month before they're put on antidepressants. This next one is the newer versus the older antidepressants. And in this one, he shows a very high rate of suicide attempts the month before, and then dropping off the first month and then dropping nicely down over 6 months. With the older antidepressants, you can see that the rate the month after was not significantly, it was greater, but not significantly so, but it was the same as the month before. So it looks like the newer antidepressants are better in treating suicide attempt risk. This is rates of suicide death after the initial prescription of an antidepressant prescription. And here you see that there's really no pattern here over 6 months. Now, analyses by Kahn, meta-analyses by Kahn of the FDA trials show that there's no difference in rate of suicide in the placebo groups that the FDA requires than the treatment groups. There's no evidence that antidepressants reduce suicide in 8 to 12 weeks. None. Zip. Based on those. It's the same. There is only one, if you ask me, Dr. Fawcett, I'm surprised nobody ever asked me this, but I ask myself this, Dr. Fawcett, what is the evidence that treatment can prevent suicide? I know of only one study that showed this. And this is a study by Jules Angst. Isn't that a great name for a psychiatrist? Jules Angst. Jules lives in Switzerland. He's like the Energizer Bunny. He's now 84. He's still doing research, still following his sample. I always say to my residents, the greatest revenge is to outlive your patients. And that's what Angst has done. He's followed a large sample of patients with bipolar and unipolar depression, most of which were hospitalized. He's followed them for 44 to 48 years. He's learned a lot from doing that. And what he found was if a patient had been on antidepressant or mood-stabilizing medications for 6 months, out of 40 years, any 6-month period, it could be longer, but a minimum of 6 months, they had a 2.5 times lower risk of suicide. Well, what does that mean? It means that short-term treatment with antidepressants probably has no effect on reducing suicide. But long-term treatment, 6 months or more, does show a signal. And so if you don't do a study that follows people long enough, you're not going to see the signal. And the only person I know that's done it is Jules Angst. So if anyone ever asks you what the evidence is, that's it. And I'm offering a case of wine to anyone that finds me another study like that. I don't think there is one in the literature. This is a study by Bauer, and he shows the same thing, that new onset suicidality was not associated with the use of antidepressants in bipolar patients. So he looked at a sample to see if they showed increased suicide risk. These are adults, of course. he showed nothing in that study. I just want to talk just for a minute about physician-assisted suicide, since we're covering the area of suicide for general medical physicians. I don't know if many of us deal with this just by ignoring it, but this is not something to be ignored. As you know, our friend and my friend, Dr. Kevorkian, in a very dysfunctional way, brought this problem to the attention of all of us. Now, I testified against Dr. Kevorkian in court in a case where he had a patient with severe vulvodynia that got worse with every procedure, and also was diagnosed with clinical depression and signed out of the hospital. This is one of the cases he put to death, and I testified against him for that case. But I understand there's a movie about him now. I haven't seen it, but he was the evidence I had. He was a pretty bizarre guy, but he did bring one thing he did do. He brought to light a problem with people who are experiencing, as they say in the Netherlands, unbearable suffering that can't be relieved, and that's a very small number. So what I've got here is a summary of reports of areas where where physicians can perform physician-assisted suicide. And one of them is from the New England Journal in 2000, and from Oregon. It has the Death with Dignity Act of 1997. And they got a 65% response from physicians. 5% of the sample had requests for lethal prescriptions. The mean age of the patient was 68. The life expectancy was 6 months average. 10% died from the administered treatment, so 10% of 5%, fairly small amount. 20% of these people had clinical depression, and in this report, no treatment was given. No one agreed to give them lethal prescriptions. 46% changed their mind after being granted this, which I thought was interesting. So this is one report. In Netherlands, they found that 1.8% of all deaths in 2005 was from physician-assisted suicide. It was down from 2.6% in 2001, possibly due to the increase in palliative sedation in Holland. So that gives us some idea of where this is going. I understand this issue has come up in a couple other states now. Maybe some of you know about that. But something that I've always been opposed to it personally, but you have to. I think you have to at least look at the arguments and review those arguments. What about suicide in physicians? As long as we're talking about suicide, most but not all reviews show that male physician suicides are higher than the general population. The rate for female physicians exceed the rate for male physicians. That's unusual. Females always have lower rates of suicide, except in China, the only country that has a higher rate in females. But they're not professionals, females in China. So female physicians are at higher risk for suicide. It's the only cause of death where physicians were higher in rates than the general population. So it is a problem in physicians. What are the factors? Well, this is summing a number of papers on this. High rates of depression. There's been a number of studies of even depression in residents showing high rates of major depression, diagnosable depression. They talk about burnout. They talk about 1/3 reporting having had depression, and especially low rates of treatment. Many physicians will not go for treatment of their depression, and that's probably the biggest problem. They will sometimes, I've seen a number of physicians that were prescribing their own antidepressants, which is not a very good thing to do, because the person prescribing the antidepressants has to have some hope for the patient. If you're depressed, you don't have much hope. So you can't be a very good psychopharmacologist for yourself if you're hopeless and depressed. Cognitive differences in physicians. 61% in one sample saw suicide as a rational choice under certain circumstances. So physicians who see a lot of death and pain tend to see suicide as more of an acceptable outcome in certain patients. And then the identity personality variable. Less likely to access help. I mentioned that. Self-reliance. I added warrior mentality. In the services and in the police departments that have very high rates of suicide, often they lose more people from suicide than on friendly fire, interestingly enough, in both police and military areas. They have a warrior mentality where you don't complain. You just suck it up and move forward. And that isn't very conducive when a person has a depression to getting out of it. And of course, the kind of stresses we all are under, both economic and forensic and otherwise, does play a part. So there are reasons why physicians may have higher rates of suicide. I think the most reversible one is access to treatment and getting physicians to access treatment. And when there's a suicide in a physician who appears to be functioning, which is almost always the case, and the colleagues, are shocked by it, then you hear, well, he didn't look quite right to me, and yet nobody did anything. Nobody said something. Nobody, because we're all so private and we all want our space. And it is a real problem among physicians. I think we need to be a little more willing to help each other and a little more outgoing with our help when we see someone that seems to be struggling, at least to ask. But it's no easy trip. I want to go back to the issue of suicide in general now, and first I want to talk about genetic endophenotypes. What's an endophenotype? Well, rather than a gene for a diagnosis, it's a gene for a trait that may run across diagnoses. In this case, the genetic risk factors, it's stated by Roy that genetic risk factors account for 30 to 40% of the variance in suicidal behavior. 30 to 40%. Genetic variants. Well, what are the endophenotypes? Brent, who studies primarily adolescent suicides and suicidal behavior at Pittsburgh, a wonderful researcher, found that suicide, there is a familial transmission of suicidal behavior, and it's irregardless of diagnosis. One suicide could have alcoholism, the other could have depression. It looks like it's being transmitted as a separate trait in families. In a study of prisoners who were positive for a family history of suicide, which were 5.9% of this group of prisoners, they found higher aggression, hostility, impulsivity, and neuroticism scores. Now, I don't know if you are familiar with the term neuroticism. It's kind of an old-fashioned term. It was first brought up by Eysenck, a behavioral psychologist from England, who was a genius, and he opposed any biological notions of mental illness. He was a true behaviorist, but he had this scale called the Neuroticism Scale, and it measured people's traits that weren't clinically ill, but had traits of irritability, high arousability, easily startled, kind of a pessimistic, not very extroverted kind of people. That this thing was years ago, and it's predicted bad outcome in so many studies. It's predicted recurrence and depression. And it was then morphed into a concept called negative affect by another psychologist from England named Watson. And it may explain a lot of our vulnerability to stress and other issues. We've just done a pilot study of people who report abuse before the age of 18, these people are over 45, who answer a huge computer interview. People will tell things to computers that they won't tell to an interviewer, and describing their abuse and its effect on their lives. And it looks like, and this was not our original hypothesis, it looks like people whose lives were badly disrupted by the abuse when they were young, and say that their lives were ruined by their abuse, compared to people whose lives were disrupted but say they've gotten over their abuse or it made me stronger, it looks like the difference is negative or positive affect, because we had a scale in there for that. And it looks like people who are most harmed by abuse are people that are born with negative affect. Interesting vulnerability study. So there is a gene which has been found that interacts, this FKBP5 gene. It's recent, as you can see, 2010. If the person had a history of childhood trauma and they have 2 copies of the risk haplotype, they've got a 51% chance of a suicide attempt. 1 copy, 36%. No copies, 20%. So there's a lot of work going on in genetic vulnerability and the effect of childhood abuse on suicide risk. So impulsive aggression, a history of impulsive aggression, getting into fights, being slighted by something and getting angry and starting a conflict, is a risk factor for suicide. It's become clear. We know that early abuse actually changes the response of the HPA axis, the hypophyseal adrenal axis, pituitary adrenal axis, is altered by early abuse, and it stays that way for life. And so there are some interesting factors that come out of that. Depression, we know, is a risk for suicide. And alcohol and drugs, we know, increase the risk. And there's a whole issue of disinhibition and increased impulsivity with drug and alcohol use. Another factor I want to tell you about briefly is comorbid anxiety. I'm watching my time here. Comorbid anxiety, there's growing clinical evidence that it may be a risk factor for suicide. 20 years ago, time flies, I did a prospective study of 1,000 patients with severe major affective disorder, and found that none of the usual predictors of suicide or the risk factors predicted suicide in the first year, but severe psychic anxiety and severe insomnia did. It was interesting because these other risk factors like hopelessness and prior suicide attempts did predict suicide at 10 years, but they did not predict suicide in the first year. That study was more or less ignored in 1990. Since then, there's been a lot of studies supporting that, especially a study, I'm just mentioning a few selected ones, 887,000 depressed veterans found significantly elevated suicide and comorbid generalized anxiety disorder, panic disorder, but not PTSD or OCD. There are studies showing PTSD related to elevated rates of suicidal behavior. A study in Norway, which is very unusual, got 60,000 Norwegians to fill out an anxiety and depression scale every month of the year except July, which is their vacation month. And from 1969 to 96. These Norwegians are stalwart people, I guess. And what they found is they had 10,000 male suicides and 3,800 female suicides in that sample. The rate of suicide correlated with the severity of depression and anxiety coinciding at the same time, which is the greatest in the spring and fall, which is true here. The suicide rates here peak in May and June, and they're the reverse in Australia. Simon had a 32,000 patient bipolar database from managed care samples that he put together and found elevated odds ratios of suicide with comorbid anxiety disorders. And he separated it from from substance abuse, which was associated with higher rates of attempts but not suicide. So there's a lot of data that's come out supporting the fact that severe anxiety and mood disorders is a risk for suicide. A guy by the name of Matthew Knock published a series of 108,000 respondents from a study of suicidal behavior, not suicides, across 21 different countries. And he found that only disorders characterized by anxiety and impulse control disorders predicted suicidal behaviors in both developed and undeveloped countries. And he developed a model, which I think explains this, that people with depression have suicidal ideation. But it's when they become increased anxiety, which can increase impulsiveness, that they act on it. So it's a two-phase model. Depression on one hand, anxiety, impulsivity on the other to get the suicidal behavior. Now, the last thing I want to tell you about is in the DSM-5, we're going to try, we don't know if we'll get this through, to have a suicide assessment guide for physicians to use, clinicians to use in assessing suicide risk. When I read charts by psychiatrists, and it says suicide in the mental status, they write down frequently no SI, no suicidal ideation, or no plan. That's not enough of an assessment. So we have reviewed the literature, and these are some of the factors that we see associated with suicide. And you'll notice that some are historical, they can't be changed, like a prior suicide attempt, or being impulsive, or a family history of suicide. We have situational factors like living alone or chronic severe pain, or a recent loss. It could be a loss of anything, but a spouse. It could be a loss of a lot of money. It could be anything in 3 months. And then we have clinical factors here at the bottom, like an increased alcohol abuse, worsening of depressive symptoms, current preoccupation with plans for suicide. That can be negative, and the person can still be at high risk. And here's what we ask the physician to decide. What concern is suicide risk in their treatment plan? We're not asking anyone to predict who's going to commit suicide, because that's not possible. It can't be done. It's been tried. It's been refuted in the literature. But every person treating a person with a severe mental illness has a responsibility to try and assess how much of their management is going to be directed toward preventing suicide. It may be zero. It may be that their whole treatment plan is focused on preventing suicide. We hope this will improve things. So, suicide can be prevented sometimes. Patients can die with their rights on. Nobody has to do anything that you suggest in this society, and patients are free. And although suicide isn't individually predictable, it is most often associated with mental illness. We're looking for acute risk factors that are treatment modifiable. Anxiety, severe anxiety, is treatment modifiable. Thank you very much. No questions? Have I saturated? Oh, okay. You got to go to a microphone, I think, to ask it. Now we got to turn it on.
looks like it's in on position. Is it on?
Yep.
What about the patient who says, yes, I have suicidal ideation, but I have 2 kids and I would never commit suicide?
Well, by itself, that means nothing, but in the context of a complete clinical evaluation, like I was suggesting in the slide one, I can't make it go back, but the factors, that's why we're suggesting people look at a number of different factors. If that patient had a history of a serious suicide attempt 5 years ago or a year ago, and they were showing say their clinical situation had worsened, their depression, that would be enough to not necessarily buy into that. Just like getting people to promise and write a contract that they won't commit suicide has been totally refuted as useful. You can't rely on it. People can tell you anything they want and still suicide. 76% of a sample of 76 suicides we studied in a hospital all denied suicidal intent prior to their suicide. So denial means nothing. A person saying they do want to commit suicide means a great deal, but the reverse means nothing except in the clinical context. If that's patients doing okay and they're just in a rough time, maybe they're dealing with something going on, it might be, if there's no other factors, it might be that you just rate them a 2 or a 3 in your concern. But you wouldn't let that alone drive your assessment.
One of the problems with suicide in the military is concern for negative impact on military career.
Yes.
You presented the evidence on physicians don't seek help. I would say that that's very possible why physicians don't seek help, especially when you have to answer the question on your licensure, have you been diagnosed with?
I think that's I don't know what the justification, I don't know if there's anyone here that writes those questions, but I don't know what the justification for that is. What does that have to do about being a competent physician? That a person's had a problem if they're not impaired now. I don't. What happens if you check that positive? Do you not get your license?
I've never talked to anybody who did.
Yeah, well, that is a problem. That's what I include under warrior mentality. And the service, if you have a psychiatric problem or in the police, you lose your gun. You lose your gun and you're behind a desk and your career is finished. You're not going to go anywhere. And that's definitely a problem. So people get a mixed message. Be sure and let us know if you need help. But if you do, you're finished. So you're right about that. It's a very difficult thing, and I don't think it yields very much to do that. Yes?
I believe what he's referring to is in the credentialing file, and everyone must be credentialed in order to have admitting privileges in the hospitals and the other facilities. And when you're credentialed, you must sign that you have not been treated for any or suffering from any mental illness.
And what if you sign that you have been?
I haven't met with that. I haven't had anyone sign that they did, but I've often wondered, and I do. Right.
Well, thank you.
You do, but what I do want to say, because I have had this problem, I think that it's a stigma for them, and I do think they're afraid to admit that, and they're afraid for their peers to see that, because as you know, as the credentialing process, your peers are going to be reading those charts and looking at your charts, and they don't want that on there. And the other reason I was told was because they feel that it's going to be negative when they try to get their life insurance. Their life insurance, their malpractice insurance. This is what I'm being told by independent practitioners. I'm seeing heads nod. that this is the reasons. I can personally tell you, just as an employee health nurse where I work, that I'm really going to go as high as 6 out of 10 of the employees that work with all of you are probably taking something for their depression, anxiety, those kinds of things. And so when I do share that with the practitioners and I tell them that, this is not something new, the majority of most of us in here probably are taking something. And it's doubtful that we could have that many that are employees but not doctors, not independent practitioners, not their assistants, are not affected by this.
Well, I agree. I wonder if anyone can defend the question. I don't know it would be an interesting debate to get someone from the medical board to tell us what the question, what does it accomplish? You think it goes to Joint Commission? I wonder if it is. Yeah. Right. Yes.
Well, what is a physician's responsibility once he has made a tentative diagnosis of depression and starts a patient on an antidepressant medication, that if the patient goes ahead and commits suicide, well, what is the liability on the physician?
Well, the majority of suits against psychiatrists are suicide suits. A lot of them are defensible. But in this society, even though it's cited that suicide is not individually predictable in an individual, if you have a suicide, a family can come back and say that you should have seen it coming and done something to prevent it. I think if you have a patient that gives you, in that list that I gave you, gives you enough symptoms that you're of concern, my feeling is, like you would with a cardiology patient, I'd get a consult and share the risk. I consider getting a second opinion sharing the risk with somebody who's a specialist and get them to assess the patient. I think it's a big mistake to go it alone when you have misgivings. With any case, I don't care whether it's what you're treating. Yes?
Is there, among people who are depressed, is there any increased rate of homicide? Is there any, in other words, is there any real reason to take someone's gun away because they're depressed? Do people who are depressed kill other people at a higher rate?
Well, depression is a risk factor for suicide.
No, but is it a risk for homicide?
Homicide.
Killing someone else?
Well, there are suicide homicides in the literature, okay? They're usually associated with, not always, but usually associated with a psychosis, a depressive psychosis, with feelings that often, some people will take their kids' lives with the assumption that life is so bad that they're going to save them from this terrible life, and it's a delusional. It's often a delusional issue. So it's a question of the type of depression and the severity of it. The reason for trying to get people's guns away when they're depressed and suicidal is that guns are the most common method of suicide in this country, even for women. So when I'm treating a patient who's suicidal or has been suicidal, I don't want them to have a gun at home. I ask every patient, and I ask them to have it removed. If they don't have to do it, but I record it in my chart that I ask them, and I usually follow up and ask them, did they get rid of that gun? It's more dangerous to them than support if they're depressed.
I gather the increased risk of homicide then is limited to people who are psychotically depressed? Well,
I can't say that there's no exceptions to that, but I can say that it's the cases I've seen where it's happened, the patients have always had a psychosis, a depressive psychosis. I don't know who's next. I go over here.
I have a question concerning your the suicidal tendency in physicians, how it's considerably higher than the general population.
Mm-hmm.
In the 50 years that I've been in Ogden, I can think of 3 physicians who've committed suicide. One of them did have a major bipolar disease. The other 2 were psychiatrists.
Mm-hmm. Psychiatrists have a
Are they higher, is my question.
There have been some studies showing that psychiatrists and other subspecialties, anesthesiologists, I believe, were highest. The question is whether those studies controlled for age. And as we know, that the risk of suicide goes up with age. Over 65, it goes way up in males. So if you study that, you've got to control for age, and some of these studies have not done that. But
all 3 of these were under 45.
Okay, well, it's not an age factor then in that case.
Wasn't here.
Right.
Thank you.
Thanks for your contribution. Yes.
As it relates to suicide, developed world versus less developed world, I can hazard a guess myself as to some of the reasons, but can you elucidate some of those?
Some of the reasons for, I'm sorry.
For the much higher rate of suicide in the developed world.
In the developed world.
Right.
Well, I'm not sure that it's higher in the developed world. I'm not sure that the rates are higher in the developed world. First of all, it's hard to get statistics in certain countries. For instance, in Islamic countries, you're likely not to get very good suicide statistics since they claim it doesn't happen. And China did not agree that depression occurred in China until about 10 to 15 years ago. Now, China is the only country that has the highest rate of suicide in females. It's higher in males than every other country in the world. And we know the dynamic. It's a woman out in the country being left by her husband with her kids as he goes to get a job. And there's a rat poison in China which is very lethal that everybody uses. And she just overdoses, and that's all she wrote. I mean, it's going to be effective every time. But China, you might call an undeveloped country in some areas still. I mean, even though they're developing rapidly. I don't know that the rates are really that much different. Some of the highest rates are in the Eastern Bloc of countries. Romania, Hungary, that kind of area. So, what are the reasons? The reasons, there's less depression associated with suicide in developed and undeveloped countries. It's more impulsivity. People with antisocial personality, impulsivity pictures. That suicide in those countries, that at least make attempts in those countries. So I think the statistics are hard to come by. But in this country, I think there are things that promote depression. I think the expectations people have a lot to do with it in the Western world. People get expectations of what life should give them and try and do things that they can't accomplish. What are your reasons?
I think maybe I misunderstood you. I thought you had alluded to the fact that the reportable rate of suicide was much higher in the developed world. So I think
I said that was a study of suicide attempts, unfortunately not suicides. And I think the reason they didn't study suicides, well, their sample was only 100,000, but they didn't study suicides, I think, because it's very hard to get statistics in certain countries. Especially undeveloped ones. Yeah.
Just a quick follow-up question on that hierarchy of suicide likelihood by specialty. What can you give us maybe the top 5 in terms of?
Well, they vary with different reports, but in general, psychiatrists have been implicated in some reports, anesthesiologists, and women, no matter what specialty they're in. It's the best I can do based on the literature.
Yes. Could you comment on how the treatment of depression in patients immediately after major cardiovascular events affects outcomes?
Well, there's been some studies of that. We know that the risk of another heart attack or a fatal heart attack is very great if you're depressed after an MI. After an open heart procedure, there's a fairly significant rate of depression that's been reported. What we don't know, the studies trying to show that you can reduce that rate have not been very successful, but it may have been because of the way one of them used cognitive therapy treatments, which we know is effective in depression and may reduce suicide likelihood, but it may not have been administered by the highest level people that were in terms of training, but I don't think it showed a difference, that study, the Good Heart study. If anyone knows that study better than I do, speak up. But I don't think it was too successful. So I think we know that there's a higher risk. The risk of suicide, the risk of death in depressed patients is as great if you have a depression as it is if you're a smoker. But that hasn't been adopted by the cardiovascular group yet. But the statistics are similar. So, but the treatment of it hasn't been very well documented, the outcome. I think that still has to be done. Yes.
I'm working down at the local Air Force base with a civilian population of about 11,000 people and about 2,500 military. There's a great deal of vexation right now about suicides in a higher rate in that community. Right. And as you said earlier, this kind of warrior mentality really is very prevalent, and yet even though we sit here in this room and enjoy our lunch, there are people who are working actively in a war. And it seemed rather obvious to me that there's this great stress, a lot of mandatory overtime, a lot of pressure from everybody right. at all levels. And yet they'll turn around and say, well, we must do something. And so they've got us at this point administering a questionnaire to every patient that walks through the door every month if they haven't had a fresh questionnaire in 30 days. And it's really not efficient or effective, I think. Right. And I don't know, have you got anything, any ideas that we could do to
Well, I've got an observation. I was asked to consult to the VA. They had an emergency meeting because they're seeing a lot of suicide in veterans, yeah. which is an equivalent, in some way, an equivalent population. And I went there and found that I was the only one on this panel that didn't have a VA study funded to prevent suicide. And I asked the question, I said, was anybody done a study of the suicides? You know, what's the data on who they were, what their situation was, were they diagnosed, not diagnosed, treated, not treated? You know, so we know who the target group is. Has anyone studied this? The answer was, somebody said they had the data, or they had some data. Nobody seemed interested in that. See, I think unless you target the people at risk, and you get an idea what is their profile, how do you, if you screen everybody, I think that what happens is you get garbage in, garbage out, and that's my personal belief. But I was not, I went over not well in that group. I found it. I left feeling rather demoralized about my role in helping the VA prevent suicide, because everybody wanted to have hotlines where people could call that were feeling bad, and I'm not against that, but I don't think it's going to prevent suicide.
We've been really frustrated there because I guess half the suicides that we've seen in that catchment, we've seen those patients and know their faces. Right. And one of the fellows was a civilian that worked in the office just up the hall from us, who would never have, I would never have guessed he was even depressed. Yeah. But, this is a very frustrating thing right now in the military and their
Well,
support
it's a difficult problem in all of medicine and psychiatry. It's an unsolved problem. But when you add a warrior mentality and a certain, it becomes very hard unless you change the whole structure of the way people can get help. I don't know what will be done with it. I think people will talk about it, fund a few programs, and life will go on. I hate to be that way. I call myself a cheerful pessimist, but yep.
Hi. I know it's a good idea to work in conjunction with a mental health provider, but I work with a large populations where they have no insurance, and so in someone that they said they have positive thoughts but no plans of suicide, I always have a hard time deciding how quickly should I, follow up with these patients. Could you comment on that?
Yeah, I mean, where do you pull a trigger? Is that what you're asking me? Is that and get and send them to the ER or someplace for a?
Well, they didn't admit that they were suicide, but they said they have thoughts and just never, don't have any plans. So how quickly?
Well, I think using using an evaluation and we don't know how much those factors that I showed you weight. What the weight of those factors are. It may be that one factor, if a patient comes and tells you, when I go home today, I've got a loaded gun and I'm going to shoot myself, that may be enough, to do it. But we know that the factors are additive from one study in China. That's all we have. So there's not a lot on this, but I think if you look at the factors like I just showed you, and you add that up, and you see a lot of acute things, plus a past history, plus a bad situation, you get more and more concerned. And I mean, I can't give you a cutoff point, but I think at certain points you need to get someone else to look at the patient with that question in mind. That's all I can tell you.
So
I know there's.
You mean like get the family involved?
Definitely getting the family involved is an important thing to do. Yeah.
Thank you.
Yeah. Thank you very much for your questions and interest. I really appreciate it.